Did you know that you don't need a six-figure sim man to teach students to think like a nurse? Case studies remain one of the most powerful tools an educator has to teach a practice-based profession such as nursing. Today, I will share a skinny reasoning case study on anorexia that contextualizes key fluid and electrolyte content that is brief and can be completed in just 15 to 20 minutes and emphasizes both critical thinking and clinical reasoning, so your students are better prepared for practice as well as the NCLEX. So let's get started. Mandy White is a 16-year-old adolescent who has struggled with anorexia nervosa since the age of 11. She admits to drinking several large glasses of water daily. Mandy has also been recently engaging in self-injurious behavior of cutting both forearms and thighs with broken glass, causing numerous lacerations and scars. Mandy presents to the emergency department with increasing weakness, lightheadedness, and a near syncopal episode this evening. She admits to inducing vomiting after meals the past 3 weeks. She is 5'5" and weighs 83 pounds. Mandy is reluctantly brought in by her mother and does not want to be treated. As the primary nurse responsible for the care of Mandy, you overhear her say to her mother, "I hate everything about me. I am so tired of living. I wish I were dead." So again, we have a very salient and a very real scenario that is from the emergency department context. What's relevant and why? Again, that foundational construct of clinical reasoning. What's relevant from what's irrelevant. In this scenario, almost all of this data is relevant. Let's get started and just kind of focus on what we have here. Number one, she has a history of anorexia nervosa that is unfortunately still a current problem. She's drinking several large glasses of water. What's the significance of that? What electrolyte will be impacted by lots of water? Do your students know that? Could they contextualize their knowledge to practice? Sodium, and it's going to be driven down. She's also been engaging in self-injurious behavior, and that's not life-threatening, but it's reflecting the mental health of Mandy. We're not just caring for a body. We're caring for a person's emotional, spiritual, and physical needs. Yes, there's physical needs here, but there's also emotional and even spiritual needs that are all contextualized, that the nurse must recognize as relevant. And to care and to think like a nurse. So let's go on. She's been having weakness that's been getting more progressive, lightheadedness, and a near syncopal episode this evening. What does this cluster of data represent? Well, in the context of Mandy, she's either fluid volume depleted or she could be having cardiac dysrhythmias that are causing these episodes. So again, we need to be thinking of both. She's also been inducing vomiting. What is that going to do to your electrolytes? And what electrolytes will be impacted by persistent vomiting, regardless of the context, whether it's gastroenteritis or anorexia? And again, our students must know this. And then you finally hear her say, "I just want to be dead." That's not only just a mental health crisis, that's a suicidal statement that also, in essence, reflects a spiritual crisis and a lack of hope. The nurse must recognize all three to provide the care needed in this context. So now the nurse collects the first set of vital signs. Her temperature is 96.2. Her pulse is 50. Her rate of respirations is 16. Her blood pressure is 86/54 with a MAP of 58. And she's got O2 sats of 99% on room air. The construct of clinical reasoning, what's relevant and why. And again, in this context, why has she got a temperature of 96.2? Well, when students understand their content, they'll know that in a patient in starvation status with a low basic metabolic rate, she's going to have a low as a self-preservation mechanism. Therefore, that's expected in someone who is literally starving. In this context, her pulse is 50. Why is it 50? Could be electrolyte issues. Maybe something else. Her rate, her respirations are good. O2 sats are good. No problem respirations, but her blood pressure. Is that MAP of 58 okay? Isn't that blood pressure okay? No, it's too low. The nurse needs to interpret this data as suggesting, again, a problem. Could be fluid balance, which is the most likely in this context. But let's keep going. We do orthostatic blood pressures. Lying down, her heart rate is 50 with a BP of 86/44. Standing up, she's 78 with a pulse with a blood pressure of 72/40. Is this relevant or why? Is this a positive orthostatic finding? Again, fundamental textbooks are not conclusive on what constitutes a positive orthostatic blood pressure. In fact, some don't even address the heart rate, which they should, because that's a compensatory response in any fluid volume deficit. And as you can see, she has had that compensatory response of going from 50 to 78. That is a clinical red flag. She's trended up. Anything greater than 10 to 20 beats up and a blood pressure drop of 10 to 20 is always a clinical red flag. She's done both. So this clearly suggests that she has positive orthostatic findings consistent with fluid volume deficit. Let's go to the nursing assessment. Breath sounds are clear, non-labored. She's pale pink, cool, and dry with 2+ pitting edema of her feet and ankles. The rest of it's unremarkable. Her abdomen is scaphoid, several 1 centimeter open ulcers on her oral mucosa that are also dry and tacky. Her abdomen is soft and tender and gentle to palpation, hypoactive bowel sounds. She's voiding without difficulty, but no menses in the last 6 months. And again, the nurse sees on her skin vertical scars from self-injurious behavior. And she's got hair on her head is thin and her skin is dry with lanugo body hair on both arms. Using the construct of clinical reasoning, what's relevant and why with these assessment findings? Well, let's start from the beginning. With cardiac, she's got 2+ edema. Is she in heart failure? No. When the students understand the significance of albumin and protein, we essentially, with her malnutrition, there's a lack of protein, the fluid is going to leach into the interstitial space, and therefore we have edema. This is expected in the context of someone malnourished. She also has open ulcers in her mouth. She's got hypoactive bowel sounds, reflecting of the vomiting that is causing ulceration with the gastric acid. She hasn't had her period in 6 months. In the context of someone who is malnourished, that is an expected finding, but it's very relevant. And then looking at her scars, you see those scars. We've got a long history. This is not just a recent problem. She's been doing this for years, most likely, unfortunately. Her hair is thinning, and she's got lanugo, that very fine body hair you see on infants. Why? Those are all things that we see in the context of anorexia and malnourishment. So all of these things the nurse must do, is recognizing the significance and why. Now we have a rhythm interpretation. Let's look at this rhythm. Again, it's sinus Brady. We also have a PVC. Is that a problem? It could be. It could be reflecting electrolyte imbalances that we'll need to now get some labs that the doctor will soon order, and we'll be looking at that next. Her sodium is 132, her potassium is 1.9, her glucose is 60, and her creat is 1.5. Let's look at what her priors were, and you can see that our trend with our creatinine has gone from 0.9 to 1.5. Is that a good trend? No, she's in acute renal failure. But look at her potassium, 3.4, which is low normal. Actually 3.5 is normal, so she's actually low there. But 1.9, that is a clinical red flag. That is potentially life-threatening, and she could go into any kind of ventricular dysrhythmia at any time, which is the reason that unfortunately anorexics die because of cardiac arrest caused by usually deficits of potassium and magnesium. Let's look at her white count. White count is unremarkable, though she's anemic, 9.8. Her white count is good, platelets are low, neutrophils are 60%. Again, with the malnourishment, you'd expect anemia in this context. No acute changes in the trends. But look at her liver panel. Her albumin is 2.4. Her bili is 0.5, alk phos is 285, her ALT is 128, her AST is 124, all key liver enzymes. Again, why is that present? Well, she's probably in some degree of liver involvement with her anorexia, and that albumin with the lack of protein is a problem. But let's look at her other labs. Her magnesium is 1.2. Her thyroid's T3, T4, TSH. Her urine pregnancy is negative. And again, that MAG of 1.2 needs to be recognized as clinically significant. And by looking at her urinalysis, she's got clear urine. Her ketones are positive. She's got negative nitrates, negative leukocyte esterase, 5 white cells, bacteria none, epithelial none. She doesn't have a UTI, but she does have positive ketones reflecting her malnourished state. And again, the nurse needs to recognize that and what that represents. And that's the first half of skinny reasoning. That initial scenario, recognizing relevance. It's about 2 pages. Now we go into 5 foundational clinical reasoning questions. Number 1, after interpreting relevant clinical data, what is the primary problem? We have a patient with multiple electrolyte abnormalities and derangements. Specifically, the most concerning are potassium and magnesium, as well as this patient is in fluid volume deficit with her anorexia. State the rationale and expected outcomes for the medical plan of care. So now the doctor wants to do a pelvic exam. We need IVs established. We need a saline bolus. Put this patient on the cardiac monitor. Begin the replacement protocol of magnesium as well as potassium, as well as an assessment and referral mental health assessment, as well as a one-to-one sitter. Recognizing why is the nurse going to do that? We need to recognize the significance of replacing that K and MAG as a foundational aspect of providing care in this context. Question 3 is looking at what nursing priority will guide your plan of care. When we recognize what the primary medical problem is, we could use the statement, the NANDA statement of a fluid volume deficit, but we also have electrolyte abnormalities and the impact on that as it relates to their cardiac status. And so therefore we need to have that on our radar as well, and the importance of replacement, putting that patient on the monitor and all that it represents. 4, what psychosocial holistic care priorities need to be addressed for this patient? They're significant. In the context of emergency department, we're going to focus on the physical needs. That's Maslow's, and it applies to practice. We've got to deal with the ABCs, specifically the B and C's. They're the C's that are present in this scenario, but the nurse must also recognize the importance of communicating caring, to be empathetic, and to communicate that this person matters, that Mandy matters to me. And the nurse needs to be intentional to do that with the little things that they can do to communicate caring. And finally, what are the educational or discharge priorities that need to be addressed to promote health and wellness for this patient or family? She's likely going to be an admission to mental health, but again, principles of therapeutic communication. In the emergency room, this is crucial. So think about the things you can do to communicate basic things, again, about what you're doing right now and why you're doing it. Why do you need this IV? She's going to question that. We need to communicate the nursing and the medical plan of care as we're providing care. And then as this patient's admitted in the inpatient setting, we're being very intentional to look at the follow-up and the principles that will be needed to look at priorities. And I want you to look at with questions 3, 4, and 5. The common theme is they emphasize priority setting. And that's a key construct of clinical reasoning as well. Recognizing relevance, recognizing priorities. Those are 2 foundations we need to establish in our students so that they have the salience to take their knowledge and take it into the practice settings and think and care like a nurse. So what did you think? Could you do this in your classroom? Of course you can. But I'd like to know, what is your go-to strategy to engage students in your classroom? I'd love to hear it. So post a comment on this video and let others learn from your journey and what you have learned as an educator. But if you're looking for additional tools to rock active learning in your classroom, I have a brand new all-inclusive membership site just for nurse educators that provides access to my entire vault of over 200 clinical reasoning case studies on over 50 topics and so much more. Click the link in the description to learn more. Finally, like this video and share with someone who would benefit. If you haven't already, subscribe to this channel to be the first in line to get fresh content that will help your students be prepared not only for the NCLEX, but real-world clinical practice.